Yeah. Good morning, friends. For all those from India, and good evening for all those in the United States. And welcome back to this weekly webinar being conducted by Andhra Medical College. This is the 85th in the series. I'm very glad that this is going uninterrupted with the help of so many of our friends in the United States, as well as those from India. And particularly to name a few, Dr. Sridhar Chilumuri, Dr. Kairam, Dr. Kalpalata Guntupalli, and Dr. Chalsani Prasad, Dr. Ravi Sharma, so on and so forth. And here we have Dr. Prem Kumar, who is regularly logging in and contributing to our knowledge. And the whole aim of this program is to see that all the problems related to COVID are discussed in detail. And after discussions, we'll have to see that it is transformed into our practice. So that's very, very important. I think we'll have to get a mechanism wherein we can ensure that these protocols are being followed in the real life practice as well. So with that aim, we have been doing this for the last 85 episodes, and this is the 85th one. And like Ram Mohan was saying the other day, so 100 is a very important number for most of us, because we all live in the world of cricket, where century makes a big difference. And at the same time, we have 100-day celebrations of most of the movies that we all look forward to. So let us hope that we will reach the 100 soon. And today, we have invited Dr. Sai Kaumudi Saride. And I'm very glad Dr. Guntupalli is going to moderate this session, because both the Bronx Care Hospital as well as Baylor College of Medicine have been contributing significantly to the this particular knowledge that they are sharing with us every week. So both Dr. Guntupalli and Dr. Sridhar Chilumuri are coming forward readily to identify the people who can give us enough knowledge. And Dr. Kairam is taking a great pain in coordinating the entire process, and he is talking to the speakers and letting them know as to what are the needs of the audience. And as you know, that we dealt extensively with acute COVID over a period of time. Later we went system-wise. Now we are in a stage where we are dealing with the post-COVID problems as well. So now I'm sure that Kaumudi is going to deal with kidney injury, both in acute phase as well as in the post-COVID scenario. So with that welcome address, I would request Dr. Guntupalli to introduce Kaumudi and start the proceedings. Over to you, Dr. Guntupalli.
Thank you, Sudhakar Garu. It's my pleasure to introduce Sai Kaumudi Saride to give the talk this evening. She is an associate professor in nephrology and chief of renal section at one of our hospitals, which is called Pavilion for Women. Although we have a lot of hospitals in India that are dedicated to women and OBGYN hospitals, it's very rare to have an entire hospital in United States that is entirely dedicated to women's diseases. And we do have one in Texas that was just opened about 10 years ago. And we see all kinds of interesting patients and problems there because it's a referral hospital. So she is chief of the renal section there. And we also have 24/7 presence of critical care with attendings there in that hospital. Sai, I have known her for many, many years. When she was a fellow in nephrology, then subsequently she was recruited to be on the faculty at Baylor College of Medicine. And she's a very fine colleague of ours, and we see them all the time in the ICU, particularly in the COVID times. Nephrology has been our partner in providing service. We are surging very badly right now. We are in our third or fourth surge, and we have expanded our ICUs from 1 to the 4th ICU was just opened on Thursday. So we have been quite busy. And so we have kept the nephrologists also quite busy. In fact, this week they had to prioritize who gets, SLED, who gets what, because of the machines and the personnel and nurses and so on. So we have been extremely busy. And Sai has kindly donated her time to several programs in India. We have traveled together to Puttaparthi and Bangalore and done several CME courses there. So she has been very generous with her time, even though her kids are young. She came and participated in several of the conferences in India with us. So without much ado, Sai, please take it away.
Thank you, Dr. Guntupalli, for the wonderful, warm introduction. Thank you, Dr. Sudhakar and Dr. Kairam, for reaching out to me and wanting me to be part of this huge project, I would say. I'm really honored to be on this platform today, particularly because it's a homecoming. I've been a graduate from Andhra Medical College, and now I am giving a little bit of what I learned in these last few years and able to share some experience with you guys. So it's really a pleasure to be here this evening, and I hope we'll all have something to learn every day. Is my slides moving? Okay. Well, for this, relevant to this talk, there's no any financial or any disclosures that I need to give. Since we had, so much of acute kidney injury and critical care disasters over the last 1.5 years, and had so much discussion about acute kidney injury, with the request from Dr. Kairam and Dr. Sudhakar, I wanted to steer my talk a little bit more towards a general kidney perspective with COVID-19. So that way we can actually look at, there's no talk without acute kidney injury in this field at this point. So we will look a little bit about acute kidney injury, but I want to focus a little bit more about outcomes of chronic kidney disease with COVID-19, and actually look at some special considerations in high-risk groups, such as end-stage renal disease, hemodialysis, transplant patients, and also pregnant chronic kidney disease, which is actually very dear to my heart, that I see pregnancy with renal disease, all the time. And then recently, there's been a lot more reports about emergence of sudden onset proteinuria or nephrotic range type or ANCA vasculitis with vaccinations. So I thought it's a nice time to look at what is happening around with these vaccinations, and definitely look at the long-term sequelae of long COVID, the so-called long COVID, particularly in the kidney. I thought this is an interesting graph to start with. I'm happy India is quite at this point after a huge devastating second wave recently, but we're still in this 1, 2, 3, and right now in this fourth surge, as Dr. Guntupalli just mentioned. It's frustrating, it's tiring, it's taking the whole lot of resources of everybody. However, with every surge, we learn a little bit more. So the reason I say this is interesting is this itself taught us how we have to be prepared for the next phase. And I hope we are at the peak of our fourth surge as we speak. The situation is really grim. This is the data from the last week in our, all the states in the United States of America. And if you see in the last week, all these southern states are running out of ICU beds again. Once more, we are up to 95 to 100% occupancy of staffed beds in the hospitals. And it is really hard even at the individual hospital levels like we just talked about. In our own hospital, we have 40+ patients in the ICU. So this is a huge burden that we are going through. And hopefully, this teaches us how we can create a hospital which is more resilient, a system that cannot be broken even if another wave comes. So we got to learn from all our experiences when we go through so many of these time and again on our heads. So moving towards acute kidney injury. I thought it was interesting to show you here that proteinuria and hematuria are, even without a drop in the serum or a rise in the serum creatinine or a drop in the GFR, are still indicators of kidney injury. So as you see that there is underlying chronic kidney disease or with age, you may see that these proteinuria and hematuria may add up along with decreased kidney function. And that actually happens because the age or chronic kidney disease or other comorbidities, they actually limit the functional reserve of the kidney. So that actually pushes down through these various stages of acute kidney injury when COVID-19 is associated with this. The risk of acute kidney injury is significantly high. We have about 30 to 50%. And the mortality risk is also quite elevated in the intensive care unit, particularly about 40 to 60%. And the mechanisms by which all of this can happen, there are quite some variety of ways in which this can be contributing to. What are the factors for acute kidney injury? I'm sure we're all familiar with acute tubular injury. When we talk about tubular injury, we have regional inflammation, direct viral infection, or even just simple tissue hypoxia causing from the various cardiopulmonary dysfunctions, which are leading to hypotension, hypovolemia, heart failure. And don't forget all these nephrotoxic drugs that we use, the antibiotics, vancomycin, commonly used in these scenarios, aminoglycosides, colistin, and also the common antivirals in the setting of COVID, some of them on remdesivir or ritonavir, and so on and so forth. So there's a lot of potpourri of things which can lead to just acute tubular injury. So the fascinating thing is it's tubular injury along with vascular injury. And the vascular injury is usually endotheliitis, microthrombi, thrombotic microangiopathy. The glomerular injury and the interstitial injury is quite low on the list, but it does happen. And you do see collapsing glomerulopathy or glomerulonephritis and some tissue interstitial nephritis, which could also be seen. What is the pathophysiology? I'm sure all of you guys are familiar with the reception of the SARS CoV-2 virus in the cell is ACE2 receptor. That is the membrane-bound ACE2 receptor, which actually on which the virus sits. And in the presence of this transmembrane serine proteases, you can see that the TMPRS, in the presence of that, ACE2 receptor activation leads to angiotensin II activation. At the same time, there could be increased myeloid cell activation leading to cytokine storm. There could be direct viral invasion as well. All of these, including hypercoagulability and microangiopathy, can lead to tubular epithelial podocyte damage as well. There could be some rhabdomyolysis, but all of these are ending up in the context of sepsis, cardiac injury, lung injury, hypoxia, and hypotension, leading to the various clinical manifestations in the kidney, from the acute tubular necrosis, a little bit of interstitial inflammation, and all of these things that we just mentioned about. So I thought it's a beautiful depiction of how the SARS CoV-2 virus actually interacts with all these organ systems within the body. There is a study that was shown from Belgium, which actually looked at all these kidney biopsies from postmortem samples. And what they looked at is all these acute tubular necrosis and vascular congestion. In fact, none of the staining had much of any glomerular disease, significant glomerular or interstitial inflammation. Again, the same thing that we just talked about. So this is really the data that could be presented initially. This was actually sent from at least 16 biopsies that were done. And most of them had immunostaining where further protein was positive, and there was some in situ hybridization as well. So again, evidence showing that there is acute tubular necrosis and glomerular congestion. Is this unique to this particular COVID? Is this pattern of kidney injury basically? There is another 26 autopsies from China by Su, were shown in Kidney International, and what you see here is aggregates in the light microscopy, aggregates of RBCs in the cells, and also some particles that they picked up as virus in the electron microscopy. So they thought this is probably an evidence of direct injury. A lot of us still question, is there a direct injury? And in their study, they actually showed that the SARS CoV-2 nuclear protein detection was also there. But then most of their finding was based on the electron microscopy. I do want to mention about ApoL1. So there is a recent data that came out, people with African American ancestry, mostly in the United States when we look at this, if they have at least 2 alleles of the ApoL1, you do see collapsing glomerulopathy. So it is something to think about, similar to focal segmental glomerulosclerosis or FSGS, which may lead to hypertension in patients. So similar to that, there could be ApoL1 genes that could be the first hit, and the SARS CoV-2 predisposition could be the second hit, which may lead to collapsing glomerulopathy. So does SARS really invade the kidney? You know, the Larson showed in Kidney International Reports that the electron microscopy actually showed some tubular reticular inclusions in the basement membrane. However, when he looked for RNA, it wasn't present in any of these tubules. So what Sue was showing earlier probably was just some viral particles, but not really sure if these were RNA of the SARS CoV-2. There has been more studies from in the New England Journal of Medicine, which actually was showing confocal microscopy where the lung PCR picked up SARS CoV-2 and the kidney PCR picked up too. And there was definitely SARS in the tubular cells particularly. So the question was, were those particles that we were seeing in all these earlier studies, were they just cytoplasmic, cellular vesicles or some other subcellular organelles, which is a possibility, or common cold viruses? So I thought it was an interesting thing, when you actually really put in vitro cell culture dishes to look at, put in a nasopharyngeal swab and treat these cells, you actually see beautiful vacuoles with all these viral particles. So something just like in the cytoplasm is probably not the same thing. And the best way to really find out would be to do immunohistochemistry, immunofluorescence. So don't just go with just the electron microscopic findings in most of the papers. They may be misleading. Is it really a virus? It could be a viral particles. So recently in CJSON, there was a nice article which showed really get to the bottom of what are they showing you that is really the SARS CoV-2 virus. It is probably invading the cells. It's just that it wasn't shown in those initial papers that we thought. So there needs to be more data that needs to come out of this. What about urine? There is association between the spike protein in the urine and the nasopharyngeal positivity. About 25% of kids and adults from Yale showed that 25% had albumin in the urine. So there is evidence that they had SARS CoV-2, they had the PCR plus spike protein in the urine, and albuminuria or organ damage was shown. What it actually shows here is those that have the acute kidney injury had high loads of the virus in the urine. And so also the mortality was high. Again, these are really the evidences that you see that in acute kidney injury, you may be shedding the virus in the urine as well. And these are the things that we really take into practice when we look at, we've stopped looking at sediments, as soon as the surgeons had, making us busier at the bedside. But this is something to really think about when there could be more transmission through the urine. Principles in the management of severe acute kidney. This itself could be an hour-and-a-half discussion. But the reason I wanted to do this is just put it here so we actually address all the issues, at least to acknowledge that there needs to be fluid balance, which needs to be individualized. Appropriate volume resuscitation needs to be done. Early goal-directed therapies in the ICU are always the starters. But again, based on markers of hemodynamics, you could use bedside focus, point of care ultrasounds to look at your volume, including the lung B lines and all of that. Aggressive diuresis, we have used it in most of the patients when we are trying to dry them out in the ARDS situations. And again, management of hyperkalemia. These are things that we do have now, potassium binding resins, which we could use. So that could be something that we could early on use so that you can delay some renal replacement therapy if you can. Treat acidosis, individualize the vent strategies again to minimize the damage, and consider renal replacement therapy. Again, this, as Dr. G just mentioned, the resources are hard in situations when we have so many patients who need renal replacement therapy. So we've been either short-staffed with the nursing or the machines or excessive patients. So it could be that you could still do SLED, which is a sustained low efficiency dialysis or prolonged intermittent dialysis. And all of these could be minimized in the best way you can use it. So that way, at least 2 of the patients could be benefited and try to move through to the next day. Patency of the circuit is another very important thing. All of the patients on renal replacement therapy, we consider anticoagulation, renal citrate, and heparin. Either of them could be used. Establish efficient surge protocols, so that way we're able to maximize our resources to the best we can do. At this point, we're actually all hands on deck. When Dr. G just mentioned, we had 4 services. Obviously, the 3rd and 4th are going to be ICU and intensivists, along with some of these subspecialty attendings who will be part of the team to help with, or hospitalists who will be. So we actually got our sheets of volunteering to see if we can come and start helping these services, because it's just getting crazy. What are the outcomes of patients with COVID-19 and acute kidney injury? So this is a nice early study that was shown from New York. I'm sure Bronx has to do with some of these studies. But what it actually shows is those with acute kidney injury and those with renal replacement therapy, there is significant burden with COVID-19. And this actually is significant risk for death. Those that have survived out of this, at least 30% still remained on dialysis. I'm kind of paving my way for the chronic kidney disease, discussing about all these studies to show the outcomes. If you actually look at Kaplan-Meier curves, which are survival curves from the hospital admission by acute kidney injury, look at these. Those that had acute kidney injury, even after 90 days, so after the initial resolution, the survivals were actually down. So there could be as much as 26% had acute kidney injury in this study, and the mortalities were as high as 50% or 54% if you had acute kidney injury. This could be community-acquired acute kidney when they come in, or in the hospital stay, they probably had more acute kidney injury. Either way, at 90 days, you see that the survival is not so great when you have acute kidney injury in the hospital. What about after they get discharged? Mount Sinai Hospital System had a nice review here, 3,000 or 4,000 plus patients here. This is also an early on study in 2020, February to 30th of May, where you see that no doubt there is significant mortality in the ICUs, but if they survive, look at this. Those that made out of the hospital, 65% actually recovered. So these are the people that we will be seeing in the next coming few months and years, and that is something we need to be watching out for. Also, acute kidney injury, irrespective of COVID, the black dots that you see here are the non-COVID, while the COVID acute kidney injury is the orange. That the difference in the slope of these is actually about 11 ml per minute of GFR. So acute kidney injury with COVID, I think there were about 182 patients here who actually recovered, but again, 3 to 6 months later, you would see that slowly the GFR is dropping, their creatinine is rising. So these again are establishing that the acute kidney injury may lead to chronic kidney disease, which is what we're going to talk about very soon. What are the outcomes of COVID-19 and chronic kidney disease? So this is a small study. Again, let's see, 280 patients with chronic kidney disease versus those that didn't have. And at baseline, if they had even as high as 1.5, creatinines prior to the COVID, and these patients with COVID, when they got admitted, look at the mortality. The CKD actually had 30% mortality, when you adjust them for all of these. The hazard ratio is actually higher for the age. So there is definitely elderly patients, higher mortality if you have chronic kidney disease, again, making them really a high risk population. If you had acute kidney injury on chronic, obviously that's another higher risk. I did want to stop for a second and actually introduce you guys to what we call the SGLT-2 inhibitors, which have been a change in the practice of nephrology. I would say the biggest discovery in the last 10 years. The reason I wanted to bring this up is we have a lot of patients on SGLT-2 inhibitors right now. These are the sodium glucose transporter inhibitors. And the common typical is the Canagliflozin in diabetes and nephropathy. What the study showed is that the change in the albuminuria, there is preservation, and look at the GFR also, looking at the change, mean change in the GFR, estimated GFR. Initially, there is a drop, but right after a year, you see that the curves started to separate out, showing that the preservation of the GFR is much better. In fact, all these studies that were done through the SGLT2, this trial actually stopped quite early because there was 30% reduction in the primary outcome, which was end-stage renal disease or doubling creatinine just after 2.5 years. So that was a huge change. And this was about 4,000 patients in this study. And subsequently, during the pandemic, we had another study which came out, which is the DAPA CKD, the Dapagliflozin, another SGLT2 inhibitor. Again, a huge number of patients, 4,000 patients with and without diabetes. And what the composite endpoint here was end-stage renal disease, death from cardiovascular causes or renal causes, and 50% reduction in the eGFR. So this study also was stopped early because of overwhelming evidence. So these drugs are here to stay, and we are going to see. And the reason I wanted to bring this up is the new current management of chronic kidney disease is trying to prevent the progression of CKD because the structural changes have already been done. They're already made before the GFR drops. So how can we early intervene? What are the things that we could use? So the only few drugs that have shown to make any difference are bicarbonate, ACE inhibitors, SGLT2 inhibitors, and obviously diabetes and blood pressure control. The reason I wanted to bring this up here is we do have in the last few months case reports that euglycemic diabetic ketoacidosis is recognized in COVID-19 with SGLT2 inhibitors. So this is the more recently, and in our experience too, we've had a couple of patients where we had to start insulin on these people. And I think I have a simple case series that was published recently. If you look at this, look at all these sugars, 200s, 140s, 150s. So there's not hyperglycemia, but severe acidemia with metabolic acidosis. And all these patients actually were on some sort of SGLT2 and had COVID. So in the context of COVID and these drugs being on board, it is something to watch out, but I'm sure these drugs are still continuing to stay because they had extensive expansion into heart failure, all of these other conditions also where they're amazingly having good outcomes. So these drugs are here to stay, and I would be cautious with that. Moving on to end-stage renal disease and transplant. Dialysis and transplant with COVID, there is a higher risk in these patients too. Look at it, about 3 to 27% of dialysis patients could pick up SARS CoV-2. The mortality risk is very high in these patients as well, up to 20% on these. So the various systems, again, renin-angiotensin, cytokine storm, hypercoagulability, again, volume or hypotension, hypoxemia, including direct invasion. So all the things that we talked about in acute kidney injury, similar to that with the COVID, you could see the pathways leading to more or worsening outcomes in ESRD and COVID. There are a couple of studies I thought we would mention here just for the interest of time in dialysis population. So this is one of the studies where 29 US states have been taken into consideration. This is about 8,000 patients. And the COVID prevalence in these there is some COVID prevalence in them. It is higher than the general population. And these particular patients actually also had higher mortality. Again, in our experience, we didn't have as much mortality, but I thought it was interesting to mention here that COVID is common among maintenance dialysis population, and they may have higher mortality just looking at some of these data. The UK also had similar data, 51 dialysis units based in London with around 5,000 or 5,700 patients receiving dialysis. And all these people, if you look at the age and their patient factors like diabetes, had higher hazard ratio. So in-center dialysis were associated with patient level factors. The rates of COVID was definitely going up in these population. These are very challenging to take care of. I do have in our own setup of, in our group of 400 to 450 dialysis patients that we follow in the city. And all these patients, in this wave of the fourth surge, we are seeing that they are getting admitted, and it's probably just the prevalence of the Delta, which is just more prone to, or easily transmissibility is what we're seeing, that they're getting admitted to the hospital now more so. So we have to see where the mortality part is at this point, but the data actually says it is something to worry about and concern. What about PD? Again, acute PD, urgent start PD is possible. We haven't done it because of the overwhelming number of patients and the resources we need. Obviously, proning is a big thing that we do in our hospitals, and that actually is working very good for the ARDS and severely acute COVID patients in the hospital, ICU. So it is technically challenging, but we haven't been doing as much, but it is possible. And you just have to have a good infrastructure to do an acute start PD. If you have the team to put in your catheters. I mean, I'm sure a lot of people in India do PD over the regular hemodialysis and transplant and all these other things, depending on what is available to you and what you can be doing. There are definitely more benefits if you do the PD. You can do gentle fluid removals, better hemodynamic stability, and there could be flexibility. In fact, nursing staff could be preserved. So you may have a lot more people, but it's just that the feasibility is going to be a little challenging when they are so sick and on the vent and prone. But it is possible. What are the outcomes in both dialysis and transplant patients? The ERA EDTA registry shows, again, significant mortality risk, about 20% with COVID in these populations, and also the other, both transplant and dialysis patients had similar mortality risks. The UK study, which is the Open Safely UK registry, had a lot of transplant recipients with high mortality again. If you look here, the transplant is actually very high. The higher hazard ratio is quite big, along with all these other liver disease or chronic kidney diseases have been really shown to have poor outcomes with COVID and transplant. This is a huge study. Actually, it's a population study, 17 million adults with almost 10,000 deaths in UK. But what it's showing is that these definitely are more vulnerable and high mortality. There's another Spanish registry also, which showed the predictors of severe COVID in transplant patients with kidney transplant. About 1,000 patients were shown with a mortality of about 20%. The most things that came out of this trial, or sorry, the study, is age and the number of months from the transplant. Post-transplant, I think if you have somebody within 6 months of transplant with COVID and they are elderly, you have worse Kaplan-Meier survival. So this is the least, and as it is, you can look at these other things. So the hazard ratios were bad for age and time from the transplant. Switching gears to vaccines. So this is, thanks to Dr. Woolley, I got this slide from her. The vaccine platforms, there's multiple varieties of vaccines that are in vogue. In US, we use the Pfizer and the Moderna. I'm sure Johnson & Johnson was there, but not anymore that we are using. Pfizer has been actually approved technically at this point by the FDA, while Moderna is still under the EUA, emergency use. The reason I wanted to bring about the vaccines here is, how is immunity in these dialysis patients and the high-risk transplant patients? There is one study, this is from early 2021, from Netherlands. Small study, few patients on dialysis, they actually got the Pfizer vaccine, which is the mRNA vaccine, and they looked at neutralizing antibodies, those which were below and above the cutoff after the second dose. What it actually finally showed is after the first and second doses, patients with long-term dialysis still had a lower response when you compare them with healthy people. In general, we always talk about diabetes and ESRD, all of them relatively have a lower immunity. So when they really looked for these antibodies, again, this is only humoral response, but after the second dose, it did pick up significantly more than the first dose. So this is just an evidence showing the humoral response to the vaccine second dose that is being given in the United States. What about the immune response in transplant patients comparing with others? Look at even cancers. Hemodialysis, much better compared to these, but the solid organ transplants have very low immunogenicity. If you look here, the percentage of the antibody response is quite low. Again, we have not mentioned about the CD4 or the T cell measurements in this study, but it just shows that there is quite poor immunogenicity in the transplant, particularly because of their immunosuppression. And similarly, in the glomerulonephritis cases or rheumatoid arthritis or other rheumatological diseases where you use immunosuppressive therapies, they actually fared a little bit better than this one. Again, individually, they may have a lot more different. The healthy controls themselves were about 95 to 100% to compare. So the question now is, we do have FDA approved for the third dose for the transplant patients. Again, we have resources, yes, but is there a need for a fourth dose is also a new question that came up in this month. Is look at the small study that was showing in all the solid organ transplant patients receiving the vaccine. After your 4 doses, at least those that were not having a response are actually well protected and now have an important run. I'm not saying we all need a 4th dose for this population when globally we don't have enough doses for anybody, but at least it just shows the physiology in trying to explain that they are weak in their immunity and they will need better protection and encouragement to get their vaccines taken care of. A quick nutshell of COVID vaccine and transplant. Transplant recipients are greater risk for severe disease. Current COVID vaccines are poorly immunogenic. Obviously, antibody neutralization and T cells. The timing is important as to when they can be given. T cells also still recognize the SARS CoV-2 and they can form in the absence of antibodies. So you have both cellular and humoral response. There could be breakthrough infections, but always prevention is better. And this is a recent roundtable webinar that came out from both American Transplant Society and American Society of Nephrology. So I thought that was good. Well, we're moving on to the next group, which is the pregnant kidney disease, which is very close to me. If we look at those that get COVID positive, pregnancy, they are vulnerable to both maternal complications and fetal complications. All of these patients, I thought it's very beautifully done from Divya Bajpai. Actually, she does along with Sylvie Shah, who is from Cincinnati. And I thought this was very beautifully done in infographic here. The pregnant patients with COVID-19, anticoagulation for all the hospitalized patients. In fact, make sure every reason for acute kidney injury has been taken care of. Rule out your differentials. You could have preeclampsia. This could be simple ATN in the context of COVID or CKD progression. It could be TTP or thrombotic microangiopathy, HILO, other lupus flare or cortical necrosis. In our practice, we did have, in fact, a couple of my pregnant transplant patients who actually got COVID and actually favorable outcomes. They actually came out without needing any dialysis or any of those while we saw the patients there. But again, in pregnancy, you have a lower threshold to dialyze patients. You early initiate dialysis if their urea is above 50 to 60, because you don't want the uremic milieu to stay longer. Intensive dialysis, about 20 hours per week. So we actually do almost 5 sessions kind of every day so that you don't make a huge fluid shifts. You get the uremia out, so the baby is growing as well. But you do have to account for gain in the weight of the pregnancy with the fetal products, about 0.5 kilo per week as the pregnancy continues to go forward. Also with the COVID and transplant, we do reduce the immunosuppression. Antimetabolites like Salsep, we decrease those. And you have to closely monitor the graft function and other drug interactions with these other medications that can be given. At home, all of these before admissions, you could be waiting to ask them to monitor their blood pressure, dipstick for protein in the urine, fetal kick counting could be looked at, and obviously COVID symptoms can be looked at. Best is always avoiding exposure, social distancing, hand hygiene, and face masks. We did use a lot of telemedicine when we used it in pregnancy with these. And in fact, with prescriptions, you can give non-invasive fetal monitoring. Again, a lot of these depends on the resources that are available to us. Yoga, exercise, and all of this is still good for pregnancy. So still encourage that. What are the outcomes? Outcomes of pregnancy with COVID and without COVID. This actually study in JAMA last year actually did not show a huge difference. If you look at the p-values weren't as great. Both the maternal outcomes and the fetal outcomes were favorable. In fact, this week, there was a study about vaccination in pregnancy. So this just came out a couple of days ago, and all of these actually received 7,500 patients received Pfizer vaccine. And if you look at the incidence of SARS CoV-2 or COVID-19 in these patients, those that got vaccinated were protected over those that were matched with the unvaccinated. So I thought this was a very positive study going forward. What are the resurgences or recurrences of native kidney diseases or sudden onset of nephrotic range proteinurias with the vaccines? We've heard about several reports of minimal change disease or ANCA vasculitis with drugs with the vaccines. And it's a nice review here, which actually shows at least several studies. These are all the nephrologists and the pathologists who were doing these studies. Minimal change de novo and relapse had been higher in patients who were post-vaccine. Most of these initially were all the first doses of vaccine within 2 weeks. Actually, if you see here, these are quite early on. And then this just points out to some autoimmunity with the vaccination. However, these numbers are very low, very small when you compare with the bigger scheme of things. IgA nephropathy has also been shown to come to be possible. And that was mostly with the Moderna vaccine that they've been given. So the PB is the Pfizer vaccine, Pfizer PNT vaccine, and the Moderna vaccine is the other one. But all of these patients were easily treatable with corticosteroids, mostly with minimal change disease were very responsive to corticosteroids. And IgA nephropathy, most of them did not need, depending on how bad their nephrotic range proteinuria or gross hematuria. But the remission, all the gross hematuria actually resolved in these patients. So outcomes haven't really been bad, but I think out of all of these, ANCA vasculitis is now more commonly being talked about with Moderna vaccine. So something to watch out for. Anti-GBM glomerulonephritis is another one, and relapse of membranous. So there's a few reports, but like I said, with the millions that are being vaccinated, this is very minimal to actually hold off on anything that we're suggesting and encouraging. This is the last couple of days ago, vaccine versus infection, adverse effects. Look at these, acute kidney injury. This is the infection of SARS CoV-2 versus vaccine. All of these conditions, the SARS CoV-2 really beat the vaccine. In fact, the myocarditis was a little bit of concern with the vaccine. Even there, if you see the myocarditis from the infection is quite high. So there is several comparisons that you can look at with pericarditis, PE, all of these conditions. That infection did more damage than the vaccine. So this, I think, is very encouraging that we should continue to protect our patients with this. I do want to mention about monoclonal antibodies that we have been using quite rampantly in the last few weeks. In fact, a few months ago, we would say 10 infusions per week. Now we have about hundreds going on every day. And the reason this is mild to moderate COVID-19 infection as outpatient. All of my dialysis patients, call me with these symptoms when they're now getting COVID positive, and if they're not that sick to get into the hospital, the FDA has approved for patients with high risk of progression to severe, which are the comorbid situations or patients with dialysis, which will be included in these cohorts. So the options we have for these monoclonal antibodies is the first one, which they were using, we stopped using because there was no same efficacy is not with the current variants that are going on in the US. So right now we are giving Regeneron for all these dialysis patients or any of these high risk, which may progress to severe disease, are actually getting this. We do have a COVID clinic at home where some of our providers are using telemedicine to monitor these patients, weekly checks for the vital signs, lung studies, more so to prevent admission to the hospital since we are already overwhelmed. So I think a lot of resource reallocation has been helpful in this instance. But again, something to mention that in the mild to moderate cases, we've been using this. I really like this. I picked up from Dr. Iwasaki, who actually showed this picture, which says, easy to understand, and I think I follow her on Twitter. The polyclonal antibodies are the ones that we all get as convalescent plasma. Monoclonal antibodies are from the single clone, and the monoclonal antibody cocktail, which is the Regeneron, which is what we are using with this, a couple of clones of this, is the antibodies against these. So these monoclonal antibodies have been shown to do it. And all my patients call, do you want me to start hydroxychloroquine? Do you want me to start ivermectin? So at this point, irrespective of their disease severity, I don't think we have a recommendation to either prevent it or treatment for COVID. We haven't been using any of these drugs on the outpatient setting. Aspirin, zinc, vitamin D. There may be small studies here and there, but no guidelines or recommendation yet to start in all of our patients. So we haven't been using any of these. No oral drugs, period. And now, long COVID. We are getting to the wrapping up the talk soon with post-COVID acute syndrome. In fact, you know, when Dr. Kairam asked me to talk about long COVID, I was looking up everywhere, and then they said, oh, don't use this word long COVID. It's called post-COVID, post-acute COVID syndrome, which is what the NIH terms it now. But I think there is heterogeneity in the names of all of this. A beautiful picture from Nature Medicine actually shows here with multi-organ dysfunction. The first 4 weeks is when you usually use your acute COVID. And then subsequently, beyond the 4 weeks is when there is post-COVID period, where you can have acute or subacute or ongoing COVID or chronic on post-COVID. In all of these, based on the systems that are being used or affected, you can see the various manifestations. Fatigue tops the highest in this post-COVID situation. Within the 4 weeks, there is still some reproducibility potential with the virus that can be picked. But beyond 4 weeks, even though you may isolate a little bit of those, it is something that you can think about that there is there if you still pick it up. But most of the time, the PCRs are negative in this time period beyond the 4 weeks. There may be some who are prolongedly shedding the virus, and you may see that. But around week 12, beyond week 12 and up to 6 months is when you really use the word post-COVID, post-acute COVID or chronic COVID. There is crosstalk and respiratory tract infection leading to all these various symptoms. I thought this was actually interesting to show. There could be hypoxemia, capillary dysfunction, inflammation. Again, this is all theories which are being suggested. All of this, even tissue hypoxia, suggesting even neurotransmitters like serotonin. So that could be an immune response mediated event or whatever is happening in this. We're still not sure as to what exactly is happening in the post-COVID, as far as I know. But we'll probably learn a lot more very soon as we see more. With the capillary dysfunction, again, from all this angiotensin 2, the capillary thrombosis, and the whole lot of cascade that can happen in the cells, along with the inflammation, can lead to tissue hypoxia and these several symptoms. Look at the various amounts of symptoms that the post-COVID situation has, the long-term effects. There is a meta-analysis that came out in JAMA just a couple of months ago, and at least 80% of them had one symptom in all these meta-analysis studies. And again, fatigue, top on the list. 58% had fatigue. And the rest of these headache, memory loss, hair loss, you can look at all of these in PTSD, OCD, psychiatric illnesses, sleep disturbances. So there's so many symptoms that are in addition to palpitations and chest discomfort and cardiopulmonary reasons, related symptoms. But all of these have been quite exhausting and frustrating to the patients who have survived. There is one study which looked at the post-COVID 6-month follow-up in the hospital. I didn't want to bother you with the whole busy slide here, but if you look at the favorite GFR, 6 months later, 35%. still had, these are just saying patients with oxygen, those that require, without the oxygen, those that are requiring the oxygen, those that are on high flow, non-invasive ventilation or IM, mechanical ventilation, any of these. So irrespective of all of those, eGFR less than 90, which is chronic kidney disease, you may see about 35% to 35 across the board, 45%, up to 45%. And this actually came out in Lancet in January, suggesting that there may be the chronic kidney disease as a manifestation of this post-COVID that we will be seeing a lot more. Again, just focusing on the renal aspect of the organ systems in the post-COVID state, the resolution of acute kidney injury during the acute COVID-19 happens in majority of the patients. So we did see if they had that acute injury, but then they survived and came out, there was significant recovery that could have happened. So there is a possibility these are living. There is reduced eGFR in the 6-month follow-up study where we saw that started to creep up again. There could be a COVIN, which is the COVID-associated nephropathy, the glomerular pattern, collapsing variant in the African Americans. So those could be there. And all these persistently impaired renal function may benefit from early and close follow-up in the AKI survivor clinics. In fact, if you look at living with COVID with all these more different organ impairments, various organ systems, they all have there is dysfunction in these, and most of the percentage of the symptoms with these conditions still have fatigue, shortness of breath, myalgias, joint pains, chest pains, fevers, sore throat, a whole laundry list of everything in various organ involvements, liver, lung, pancreas, heart, kidney. Interdisciplinary COVID clinics. This is the way to go for the long COVID or this post-acute COVID state. We do have our own clinic that we collaborate with our pulmonologists, and our access point is the pulmonary physicians who actually run the clinic. I'm sure Dr. G can explain more about how her experience in the clinic is. But the way we've been doing at Baylor is a bunch of questionnaires are given. They evaluate and prioritize these patients. They direct to subspecialties. They're building up a registry for these patients. And we do have resources with patient navigators and coordinators who are supporting the clinic. So the most important and common symptoms that all of us see in these clinics is autonomic dysfunction related to either postural hypotension related symptoms or cognitively brain fog. A lot of these patients are actually being hooked up for cognitive training or testing at the PMR, collaboration with the rehab facilities. If it's really to the point of memory loss, dementia clinics are part of the clinics. So neurology has been helpful. In fact, ENT has been helpful with, say the smell and the taste retraining when patients actually forget to have those things. So they're in fact actually talking about sinus washes with theophylline and things like that, very fancy. But there are things that could be done in this population that I think we could really look into and help. Apart from this GI, again, a lot of IBS type of symptoms for the GI. Pulmonary is the first part where the interstitial lung disease, shortness of breath, dyspnea, that's all continue, rehab and exercise programs have been suggested to most of these patients. And if they actually see that the creatinine is creeping up, the nephrologists are involved in this care as well. And that's where we like to follow them more closely and hopefully prevent or halt with all the things that we just discussed about in chronic kidney disease management, that place where we help. Thromboembolic phenomenon is the other significant issue that they see, most of the time, somebody coming in now with a clot in the lung or the DVT, where anticoagulation. So there's a whole lot of things that need to be figured out and help in these COVID, in this long haulers or the post-COVID long clinic, where multidisciplinary approach is the way to go. And in a quick nutshell, since there is resolution of AKI, we will see more of them. The reduced eGFR gives us more business. The burden of dialysis is not as much here, and early and close follow-up of chronic kidney disease may bring better outcomes, as was shown even in the pre-COVID era. And with that, I want to sum up today's talk with high mortality in acute kidney injury, Chronic kidney disease could be followed up closely and helped. Encourage vaccines for everyone with the data that I just showed in the special populations of dialysis, transplant, and pregnant patients. And halt or delay the kidney, CKD or chronic kidney disease, and support these interdisciplinary COVID clinics and AKI survivors clinics. I'm sure we'll see a huge tsunami of disability which is coming as a result of this long COVID. And we need to plan for the future. I really like this article from Scientific American, where it said, we need to plan for a future where millions of survivors are chronically ill. So that's a huge statement. And with that, I will stop. Thank you.
Thank you, Sai. That was excellent. I'm monitoring the chat box. I don't see any questions. Maybe if anyone has questions, they can raise their hand, or can we stop sharing the screen so we can see everybody?
Dr. G, I have a couple of questions.
Go ahead, please.
Kaumudi, I had been curious about which of the organ system does this virus directly affect. For example, there is not much evidence it directly affects the cells of the nervous system, neurons, oligodendroglia, or microglia. Similarly, in the kidney, you mentioned podocytopathy, endotheliitis, microangiopathy, but is there any direct evidence, especially when it comes to glomerular injury or tubular injury? Is the virus seen directly damaging those cells, or the early studies showing the virus on electron microscopy? Yes, it is present there, but is causing disease in those cells, or is it entirely related to the vascular injury? I'm curious.
That's a very good question. And in fact, the couple of slides that I showed you earlier, that when you have acute kidney injury and the virus spike protein is being found in the urine, there is a connection for both. And if you do in situ hybridization or really look for the SARS CoV-2 protein in the cells, you would pick up in the tubular epithelial cells, not so much in the glomerular that I'm aware of, but in the tubular, because of the ATN that you see, you could pick up when you really do these in situ hybridization or the specific RNA testing, you will find them in the tubular interstitium. That's the fascinating part.
Are we finding it there, or is it causing disease there?
Well, it definitely attacks the proximal tubule. We just don't know whether that is the, the whole cascade. It's a multifactorial process, definitely. But to some component, there is direct invasion. The magnitude of evidence is not there as much, but there is some evidence showing that there is, if you actually pick it.
Thank you. Dr. G, before other questions come up, but I'm very curious to tell both of you, being in Texas. Comedy, I'm new in Texas. Texas population is 30 million or 29.5. It appears there are 10 million people in Texas who are medical researchers. They don't have a high school diploma. They come to my office, there is no mask, no vaccine. They're telling me that they're waiting to evaluate further data. They have the ability to monitor and evaluate data that is being submitted to the FDA. And when they are convinced, they will take the vaccine. In the meantime, they are coming to my office, no mask, no vaccine. So I did not know Texas was so richly blessed with so many researchers. It is so sad.
Point very well taken. And I would just say it's a red state.
Yeah, red patients also get medicine. I mean, they get sick, and when they're sick, they go running to Kalpalata Guntupalli, don't they?
Just today, one anti-masker died of COVID in Texas. I just saw a tweet from, Peter Hotez. So,
it is the place where we have the vaccines developed. Yes, sorry, go ahead.
No. Wait, one second. Dr. Ramesh, just hold on a second. Let her finish, please.
Please go ahead.
So, there is this whole anti-vaxxers in our area, but again, the morbidity and mortality is what we're seeing and so frustrating. So yeah, I'll let you go ahead.
That is why, actually, when I finish today, I'm going to go and find that poster that you showed between vaccination and the disease itself. Is dramatic.
Mm-hmm.
Should
Yeah.
be blown up and put on our window tomorrow, because that's amazing how people are blaming vaccine. So in the vaccine, I have one last question. In the minimal change nephropathy that you mentioned as a result of COVID vaccination, is that special to COVID? Does it happen with flu vaccine? Does it happen with other vaccines?
Yeah, again, very good question. There were episodes before with the flu vaccine too. Again, this is talking about, is there an autoimmunity development when you have a vaccine like this? Very minimal numbers that you can count on fingers that you're seeing these. But it has happened with the prior vaccines too. Yes.
Okay, thank you. Dr. Ramesh, you're on.
Yeah, hello, madam. That was a wonderful lecture we got early morning on Sunday. That was really covering the entire extent of nephrology, from clinical nephrology, dialysis, and transplant relating to COVID. That was very excellent. Actually, I had some questions like, why is that virus have more predilection to? Actually, an associate professor in nephrology in Andhra Medical College. No, why is that virus particles have more predilection to the tubular epithelial cells rather than the glomerular endothelial cells or the podocytes? And I was just curious, just now I got a thought whether urine can become a transmitting agent to this virus, apart from the throat swab. Just curious. Just wanted to put that question.
I think that those are excellent questions, and that's the research we really want to have answers for, is why is this more a predilection to the tubules over the rest of the things? However, endothelium still gets injured because we do see microvascular thrombi, we do see microvascular injury, clots within the microvessels. But specifically about the transmission, as long as you don't pee everywhere, you're good.
And actually, have you seen any graft dysfunction following COVID? Actually, we had one case of, we did a transplant, one young lady, 35 years of age. And then for 4 years post-transplant, she got COVID. And then slowly there was deterioration in graft dysfunction and she came back on dialysis. So did you see those kind of scenarios?
Yeah, we see them all the time because, with the prevalence of the infection more in the community, the transplant patients are picking it up and coming in with. As far as graft complete loss, I haven't seen that yet. There is some dysfunction, particularly when we do the biopsies, it's ATN. So you wait, you just reduce the immunosuppression, hoping the rejection won't happen in these patients. So with my, limited experience here so far, haven't had much of loss of the grafts yet.
Have you seen any progression of CKDs from CKD 2 to 3 or CKD 4, progression of CKD following a COVID vaccination?
I think that is too early to say. Again, in the long clinics, these are post-COVID situations. Post-vaccination, I don't think we had any concern about progression of chronic kidney disease. I don't think so.
Sai, there are some questions. There are some questions. Your batchmates are saying hello to you, and
oh, thank you.
I have their names and I'll send the message to you. The one question is, how safe is remdesivir in ESRD?
So it is really not safe, anything less GFR less than 30. However, when you are looking at life and death situation that we still have to give in terms of, is this the only treatment that you're in this particular patient? So individualizing specifically, that the guidelines say less than 30, don't do it. But if it's a informed decision, if this is somebody with a severe critical illness and somebody who made a decision with the teams together, we have had patients who got remdesivir with worst GFR.
Hi, Kaumadi. Kenneth.
Yes.
You have seen any fungal pyelonephritis post-COVID?
Mucormycosis has been definitely, in the initial few waves. I think after the first couple of waves in our county hospitals, we had mucor, definitely cases of that, but not as pyelonephritis. No.
Okay.
So
we have seen some patients of causing fungal pyelonephritis and raising creatinines.
Oh, wow. Yeah, it will be challenging. The treatment again is going towards the antifungals, and you really are now.
Yes.
So yeah, that's a very good point.
Yeah.
Dr. Suresh from Australia, proud batchmate of Sai Comedy. Thank you, he says.
Welcome, Suresh.
So another question is, can you summarize your point about COVID and SGLT2s? We see a lot of people on data and empagliflozin.
Yeah.
We don't see Canagliflozin here.
So the main point about this is these are drugs, wonder drugs that have been started in diabetes and nephropathy, and they will be here. We are seeing metabolic acidosis and euglycemic DKA. So do we stop? Is it like, do we stop the ACE inhibitor when you see AKI? It's as simple as a question like that. Now, the long-term outcomes are good, but in the setting of COVID, when you see everything is off in your charts, I'm going to hold off for a few days and then reassess in the clinic and restart them, because these are supposed to be helpful in the long term, So empagliflozin, we do have it in our county. Canagliflozin, I mean, these are all similar class of drugs. Some of them have actually a lot more amputation risks. The most worry that I have with the SGLT2s, though, is frequent UTIs, because a whole lot of glucose is going into the urine. And so they do see frequent UTIs and 4 years gangrene. That is really devastating diagnosis some of the patients had that we saw in the hospitals.
The next question is, please comment on the use of cytokine filters, cytosorb filters in dialysis for treatment of severely ill COVID-19.
Oh boy, you guys are really resourceful. So there is some data about it. We haven't been using any of these cytokine filters. Even pre-COVID era, the cytosorb or interleukins and filters which could be taken, the cytokines out. There was a lot of push for these, but none of the long-standing data showed anything that was recommended. And again, who knows, after today, the new data comes in a week or two, and then we'll all be starting to use. So far, we haven't been using any of those.
Dr. Guntupalli, I would like to ask the questioner if there is anybody collecting data on the value of the cytokine filters. They may be giving it because it's available. I was curious if there is anybody either at All India Institute, or is there any statement from ICMR? Yaramili, do you know of anybody doing any kind of study? Otherwise, we'll never know whether this damn thing works.
Good evening, Dr. Kairam. So I have seen cytosorb filters being used in private hospitals in Vizag, and one of the patients have come out with excellent results. That's the reason why I have asked this question if Dr. Sarde has any experience with use of cytosorb filters, because the IL-6 levels, which were very high, just after one session of dialysis, they had come down tremendously. That's the reason why I just wanted to know your experience.
Yeah, unfortunately, no experience on this, but I did read about it. Definitely publish it. So the more we see, the more will be the push.
Thank you so much.
Any particular race, it says any particular race is more prone to land in AKD in COVID-19?
Acute kidney disease is what they're meaning by the
AKD. With COVID-19, yeah.
Well, depending on where you are coming from, if you're talking about in the United States, a lot of non-Caucasians, the Hispanics and the African Americans, we have seen a lot more acute kidney injury. But I think when we looked at the all mortality, these socioeconomic factors did not really show up in huge studies that these are higher. But in our own practice, we do see that these people, particularly the African Americans, again, with the APOL1, have a higher predilection, but Hispanics and non-Caucasians actually had a higher risk here in the United States. Yeah.
And actual COVID risk is like 3.8 times more in Native Americans, followed by Hispanics. So they are like Hispanics is like 3 times. That's why most of our hospitals are full of Hispanic patients in Texas. There's another question. Any lupus nephritis class transformation following COVID?
Not in our experience yet. Again, these are people who are on immunosuppression. So yes, that would be something to watch out for. I have not seen anything yet.
I think post-COVID, at least in our clinics, the number one, I do the post-COVID clinic, it's me and a psychiatrist, because psychiatric problems are the number. I'll tell you, there's something called post-ICU syndrome, which we have known for more than a decade. But these post-ICU clinics, nobody can fund it because the billing, I mean, you know, it's all financial here. So they were not very popular. Nobody would fund it. Now, post-COVID clinics, everybody's funding because there's state funding, there's visibility and so on. But this, that they would have a third to 40% would have psychiatric issues. The physical part is neuromuscular weakness, which is most common, can present up to 1 year. And then you have the cognition part, this brain fog, or, you know, somebody who was a CEO now can't function, who was an accountant can't count. I mean, could be very subtle or very gross. And then psychiatric. So 3 aspects of these: physical neuromuscular weakness, most common. Number 2 is cognition, and number 3, psychiatric, which is again depression, PTSD, and anxiety. All of those are almost a third to 40%, which is what we are seeing. Whether this is just a prevalence of what would have been in the community in a post-ICU syndrome, or is this more specific to COVID, we don't know. But I find the psychiatrist to be the most helpful for me. So almost half of the patient, we do the screening, all the screening tests for cognition, psychiatric, PTSD, depression, all of those. And quite a number of them come out positive, and then they treat them. I have seen some with very severe wasting because they've been in the ICU for 2 months. People who came in normal, now they're wheelchair bound with a lot of wasting. So, I mean, I don't know how much of it will recover. Lung, of course, we'll see quite a bit of shortness of breath and, being on oxygen that they were not before. A lot of them will come off of oxygen and get better. But there are some patients, I mean, if they're admitted to ICU or if they're admitted to hospital and do a CT, you'll see a lot of changes, obviously, and then they may go away. But I think the next big thing, especially for India with so much of numbers of patients, is the lung disease, fibrosis, that they're going to come up and see.
Yeah.
I don't see any more questions in the chat box.
Dr. Sudhakar?
Madam, may I, madam?
Oh, yes,
Yeah.
there is another person who wants to ask.
Hello, everyone, madam. Nice talk, madam. Really, what you said, the speaker, what you said is wonder molecule, the SGLT-2 inhibitors. Really, the nephrologist and the cardiologist treating diabetes and kidney disease and diabetes and heart disease are very much excited to the extent saying, can we use it? People are also thinking of, can we use it in without diabetes, kidney disease, and without diabetes, heart disease? They're also so excited, madam. That is one thing, madam. Dr. G was asking our principals are last week, has India entered a third week, third wave? The latest update from the government of India is as latest as 2 days. It says India is in the midst of a second wave, madam. India is in the midst of a second wave, and the National Disaster Management Institute just submitted a report to our Honorable Prime Minister saying India may touch a peak of third wave in October, madam. That's what, that is the update, madam. And we have got one more vaccine from Zydus Cadila, Indian-made vaccine, madam. It is a world's first DNA-based vaccine. It is a 3-dose vaccine, madam. It's not an injectable type of, it's not an injectable because it is meant for plus 12 years. They made taken precautions to avoid the children might hold back an injection. So just a prick type simple some mechanism they are using, madam. It is a 3-dose vaccine. That is the latest update, madam, on the vaccine side. That is the 6th vaccine to be available in India, madam. And Sputnik Light is also coming, madam. It is only a 1-dose vaccine. That is another update on the vaccine side. The trials are also on in India, madam, from Dr. Reddy's lab. Sputnik Light, madam. That is the thing, madam. Thank you, madam. Thank you. Thank you for the opportunity, sir.
Okay, Dr. G. Otherwise, I will ask Dr. Sudhakar if the things with vaccination in India and Andhra Pradesh has improved.
Yeah, quite significantly. As of today, now that we have 5 crore population in Andhra Pradesh, and 2.06 have been covered with at least 1 dose of vaccine till last night. And if you take away the children population of about 1 crore, I think more than 50% have been vaccinated so far, all the age groups put together.
Go ahead, Dr. G.
Sai, your classmate Suresh again from Australia is asking about any breakthrough infections that we see here in USA or in India. And he says, Sai Kaumudi, thanks for summarizing in one of your slides about unnecessary and ineffective treatments. Show that slide again, if you can.
Sure.
So breakthrough infections after vaccines is what he's asking. What are you seeing in India and what are you seeing here?
Yeah, I don't have much of information from what is happening in India about the breakthrough infections, but a lot of healthcare workers are having breakthrough infections. You know, we did have, in fact, it is funny that I took it off on Friday because I had upper respiratory infection. You know, we were all been working, haven't tested yet, but that is a truth. However, they have not been as sick to be admitted in the hospital. So there may be an infection because you're still able to contract the disease despite having the vaccination, 2 weeks after your second dose. However, the severity is what is being protected from, and none of these actually had to be hospitalized. So there is a concern. However, this is in the context of the Delta variant, I would say, and we are all getting ready for our 3rd dose soon. It hasn't been approved for the general public yet. It has been approved for the immunocompromised and the immunosuppressed. I do see another question from Dr. Sudha in the chat about the 3rd dose. When is it being given and taken? So the lower immunity, definitely people with immunosuppression have been approved to go ahead with the 3rd dose. Healthcare physicians, it should be opening up very soon for all as well. I think they're waiting.
It's already the booster dose. Many hospitals are already giving it, although it's not publicized yet. I know Texas Children is doing it, Methodist is doing, Denver, Colorado. I mean, a lot of hospitals, and you can just go on cvs.com and get the booster. I got mine without, because I'm close to a year. So breakthrough infections are supposed to be like very minimal, maybe less than 5% or 1% or whatever. But I have seen with this, we are not routinely measuring Delta variant in Houston. They're supposed to be going to the city, but I have not seen any data coming back. What is the percentage? But looking at CDC's data, it is quite high in many of the states. And I have seen many of my colleagues in our department, in our critical care, a number of fellows and faculty who've turned positive. Like you said, they have been symptomatic, but none of them even needed to go to emergency room or anything. were manageable at home, but they're all quite young in their 30s.
I
So-
have a quick comment regarding the third shot. I took it last Wednesday. I became increasingly concerned because the 10 million researchers in Texas are walking all around me. And they don't have masks, they haven't taken vaccines. So I said, I should go ahead and get my third shot. So the comment I want to make is about the word breakthrough infection. All along we knew Pfizer and Moderna were 90% effective. 10% they are not. We did not routinely measure antibody status after routine vaccination. So if you already got immunity, if you already got enough antibodies, and then you got infected, then it's breakthrough. This ain't no breakthrough. Maybe you are in the 10% and you got it for the first time. I don't think we are explaining that well. Dr. Dr. Comedy, you agree with me?
Absolutely, sir.
So in this,
we don't know. If it depends on how far, what is your immunity status after 6 months, 8 months, we don't know. We are saying 8 months. We don't know at 6 months, none of this is, although the Moderna and Pfizer, they're all drawing blood and everything. I haven't seen the final data of what is the decay of antibodies, if somebody is, I've seen patients who are in immunosuppression, who got COVID after, since we don't measure the antibodies, I've seen them get, so maybe they never mounted antibodies like you showed in some of your slides. But these are young people like in their 30s who are working every day. I don't know what happens if your exposure is so high. You're seeing 15, 16 patients, 12 hours, we're at bedside, you're proning them, we don't know. But at least the good news is the disease seems to be mild. In pregnancy, can booster dose be given? Booster dose.
It hasn't been approved yet for the pregnancy, but it'll become part of the general public. Mhm.
Says we have lost a young nephrologist of AMC, Dr. Srilata, in a gamut of COVID, dengue. Let's all pay homage to her.
understood. Yeah, it's been in the news a lot. Apparently, they assumed it was COVID, but she was dying of dengue fever.
So that's rampant in India now.
Right. Oh, I have an answer for Dr. Ramesh Chandra. I made a lot of inquiry and I spoke to the person who seemed knowledgeable. The third dose of the vaccine is the same as the second dose or the first dose. I confirmed that. It's not a new dose. It's not, because he said to me very clearly, if they created a new vaccine to cover the new variant, it has to go to FDA again. So it is the same shot.
That's the same dose, same shot.
Same shot. All right, Dr. Sudhakar.
Yeah. Now, if there are no questions, I think we can wind up this session. And thank you very much, Dr. Kaumudi, for a very elaborate and extensive talk that you have given and very ably answering all the questions. My particular thanks are due to Dr. Guntupalli for conducting the proceedings and answering the questions as well. As usual, Dr. Ram Kairam rose to the occasion and bridged the gaps and tried to answer individuals who have been posing questions directly for everyone as well as individually. And thank you all. And we'll be meeting again next Sunday this time, Saturday for you all. Ram Mohan, would you like to make a comment?
Yes, I want to say.
Yeah, Ram Mohan.
I was an intent listener today. I want to say that she delivered a lot more than what I asked for. Thank you very much. And next week's speaker would be a neurologist, Dr. Manjeet Dhallu. He's the chief of neurology in Dr. Sridhar Chilumuri's hospital. And I talked to him extensively about both acute neurology and long COVID neurology, post-acute. So same time next week.
Thank you.
Thank you, Dr.
Yeah.
G.
Bye.
Thank you once again. Thank you.